Thank you. I would like to thank the organizing committee for this great opportunity to talk about this interesting topic, treatment of patients under anticoagulating or antiplatelet therapy. Do we have the skills and equipment? I think all of us as urologists have faced or we're going to face to treat patients under anticoagulating or antiplatelet therapy. In these cases, sometimes can be very challenging. Very briefly, anticoagulants, most commonly used anticoagulants, as we all know, is warfarin, heparin, unfractionated low or low molecular weight heparin, direct-acting oral anticoagulants like rivaroxaban, apixaban, edoxaban, antiplatelets like aspirin, clopidogrel, prasugrel, ticagrelor. We have all of us, we have to know, as surgeons, we have to know the different kind of mechanisms that these agents work and how do they interfere in the coagulation cascade, or as well as the pharmacokinetical properties of these agents, like half-life and peak onset of action. In general, there are 4 strategies: managing antithrombotics in perioperative period, delay surgery until antithrombotic agents are not needed, stop antithrombotic agents prior to surgery and restart sometime after surgery, administer alternative antithrombotic agents in the form of bridging, as we all know, using for example, low molecular weight heparin when warfarin has been interrupted, or continue the antithrombotic therapy through the surgical procedure. We have to remember that there is a cumulative risk of bleeding. Bleeding can occur during the first 4 weeks after surgery. Usually 50% of major bleedings occur between surgery and the next morning, and around 90% of bleedings occur during the first 4 post-surgical days. In contrary, the risk of venous thromboembolism is almost constant during these first 4 post-surgical weeks. Of course, there are many committees, institutions, organizations that they have tried to yield some guidelines and recommendations, weighing risks and benefits. All clinical practice guidelines and recommendations discuss the need for the surgeon to weigh the risks of perioperative bleeding against the risk of thromboembolic complications. Use risk stratification approach to know low or high risk for venous thromboembolism, or additionally, if there is the patient if it is considered to be a low or a high risk for bleeding. But unfortunately, there is no clear consensus for the perioperative management of antithrombotics. We have to note that when we're talking about antiplatelet therapy, there is a great difference between single antiplatelet therapy and dual antiplatelet therapy. For dual antiplatelet therapy, if possible, defer any elective procedures until the completion of dual antiplatelet therapy course. This is what is, in most cases, is advised. For emergency operations that cannot be delayed, then by all organizations is encouraged a multidisciplinary approach, consultation between cardiologists, hematologists, neurologists, and urologists, for example. The AUA guidelines and we will see later, EAU guidelines have some differences. The AUA guidelines mention procedure-specific guidance. Ureteroscopy is considered to be a low-risk procedure for bleeding. ESWL and PCNL are considered to be high-risk procedure for bleeding. For the EAU guidelines, in EAU guidelines, patients that are not in very high risk of thrombosis and they are on antithrombotic therapy, the panel's recommendation is to stop antiplatelet or anticoagulant agent before surgery and not initiating any alternative antithrombotic therapy. This is a high-quality evidence and a strong recommendation. Restart the antithrombotic agent when bleeding is no longer a serious risk, typically 4 days post-operatively, rather than withholding for longer periods. For patients with very high risk of thrombosis on antiplatelet therapy. And who are these patients? These patients are with drug-eluting stent placement within 6 months, bare metal stent placement within 6 weeks, stroke or TIA within 30 days, recent incidents of venous thromboembolism within 1 month, severe thrombophilia or mechanical heart valves. For these patients, very high-risk patients for thrombosis in whom surgery can be delayed, it is strongly advised to delay surgery. For patients with a very high risk of thrombosis who are on anticoagulation therapy, with a new, for example, with a new recent venous thromboembolism episode, delaying surgery for at least 1 month and, if possible, 3 months to permit discontinuation of anticoagulation preoperatively, rather than operating within 1 month of thrombosis. Strong and high-quality evidence. For patients with severe thrombophilia and mechanical prosthetic heart valves receiving warfarin, panel's recommendation is to discontinue the anticoagulant agent and do bridging with, for example, low molecular weight heparin. We have, for sure, we have to know when to stop before surgery. This period of time is different for its antithrombotic agent. For example, for warfarin is 3 to 5 days. For direct acting oral anticoagulants, 1 to 3 days. For antiplatelets, aspirin, for example, 3 to 7 days. And for clopidogrel, prasugrel, ticagrelor, 5 days. We have to remember patients' comorbidities. The patients who are going to treat have comorbidities. They are different in terms of age, BMI, and as we know, comorbidities increase with age. Common comorbidities among patients with urolithiasis are cardiovascular disease, particularly hypertension, diabetes mellitus, obesity. Complications increase with number of comorbidities and risk factors, and anticoagulation is considered to be a risk factor. Ureteroscopy is generally recommended as first-line therapy for a patient requiring intervention with an uncorrected bleeding diathesis or requiring continuous anticoagulant or antiplatelet therapy. And is it easy to do ureteroscopy? Are there any complications when we treat patients while being on anticoagulation? As we see here, anticoagulation is a risk factor. In this ureteroscopy global study by the Clinical Research Office of the Endourological Society, we see that patients on anticoagulation had the highest percentage of complications, 7%. The bleeding complication was significantly higher in patients who were on anticoagulation therapy compared to patients who were not on anticoagulation therapy. We have also to know that the rate of complications increases when we talk about ureteroscopy. The rate of complications increases with the increasing number of risk factors. The more the risk factors, the greater the risk for complication. Complication rate increase also or depends also on the different combination of risk factors, but for sure the higher risk factor, the more dangerous to have complications after ureteroscopy. There are studies that have shown that continuation of anticoagulation and bridging are both associated with significantly higher risk of perioperative bleeding. Among those with continuing anticoagulation therapy, all bleeding-related events were significant. And for example, here we see in this study, 15.4% of patients had unplanned return to operation room, the most common complication. And important here to see that 75% of these cases requiring a return to the operating room involved the direct acting oral anticoagulant agent as opposed to warfarin. Bridging is also dangerous or is also related with the increased rate of bleeding. Patients who bridge with enoxaparin, for example, had a high rate of significant bleeding despite holding their dose the morning of surgery. From studies, we see that perioperative bridging is controversial. Although the benefit of bridging is questioned, the risk associated with discontinuation must also be carefully weighted. Important to know that the direct acting oral anticoagulating agents have greater bleeding risk than warfarin. Other factors related to ureteroscopy which are considered to be also related to bleeding, to complication rates are, for example, pre-stenting. Pre-stenting, we have seen that pre-stented patients had a low rate of significant bleeding. Patients who had ureteral dilation were more likely to return to the operating room. Longer operative time was also more likely to have an unplanned return to the operating room. Interesting, with stone size, there was no any significant correlation with between stone size and bleeding. Regarding antiplatelet treatment, continuation of antiplatelet treatment during ureteroscopy does not pose significant additional bleeding-related risk. We have seen that patients who had held the antiplatelet agent and those who continue to receive single antiplatelet agent had similar bleeding rates, not statistical significant different. Only the dual antiplatelet treatment appears to have significant higher bleeding complication rate. Indeed, dual antiplatelet therapy was also associated with a higher all-cause 30-day readmission rate, for example, Plavix with aspirin. However, there are some other studies with controversial findings. For example, in this recent study from Hiller and colleagues in 2021, the researchers found no significant bleeding complications from ureteroscopy in patients who were receiving antiplatelet or anticoagulation treatment. Antiplatelet therapy was significantly associated with increased hospitalization after ureteroscopy. What about PCNL? PCNL, is it safe to perform? There is a growing clinical interest to investigate the safety of PCNL in patients receiving antiplatelet therapy and in particular aspirin. However, until now, there is limited data, small retrospective studies with small number of patients, single-centered, so there are not really safe outcomes to say. In a recent study from Otto and colleagues in 2018, patients who were receiving low-dose aspirin, the researchers found no similar outcomes, no significant difference regarding blood loss, residual stone fragment size, length of stay, hemoglobin drop, and need for transfusion. So do we have the skills and equipment? I think we all agree that the technological advancements in endourology have given us this opportunity to be able nowadays to try to treat patients in these challenging cases with while being on antithrombotic treatment. Of course, the miniaturization of endourological endoscopes play a crucial role. Miniaturized endoscopes cause less trauma and reduce the risk of bleeding. In PCNL, particularly, the smaller tract causes less trauma and there is a reduced risk of bleeding. The evolution of digital flexible ureteroscopes, the so-called new next-generation flexible ureteroscopes, the development of single-use flexible ureteroscopes, all these achievements have increased globally the availability of ureteroscopes and made the ureteroscopy more popular. Other technological aspects of endourology, like the advanced digital imaging quality with this chip-on-the-tip technology, for example, in ureteroscopes, and improved visualization that offered digital tip design of ureteroscope, if it is tapered, for example, or oval, wide range of deflection capabilities, active secondary deflection, continuous deflection, S-shaped deflection, and so on, allowing access to any area of the intrarenal collecting system, improved ergonomics and maneuverability of ureteroscopes. All these benefits of digital flexible ureteroscopes, like improved visibility, reduced operative time, reduced need for high intrarenal pressure, all these benefits allowed us to have potential reduction in subsequent complications like infection or bleedings. Other important parts of endourological armamentarium, like ureteral access sheath, they are available in a variety of sizes and designs and have evolved to fit the ureteroscope. We all know the advantages of ureteral access sheath, the easy re-entry for the ureteroscope, prevention of increased intrarenal pressure, maintenance of good visualization, reduce operative time and morbidity. There are some novel vacuum-assisted ureteral access sheath with aspiration of stone fragments. Variety of irrigation systems like the automatic irrigation pump and novel irrigation and at the same time aspiration devices. Of course, the various high-power laser systems like Holmium YAG laser with MOSES technology or recent thulium fiber laser which have improved the stone with promising results in stone fragmentation and potentially reduced bleeding complications. So all these technological advancements in endourology provided improved efficacy, stone-free rate, reduced operating time, less trauma, less bleeding, and for sure the indications for flexible ureteroscopy have been markedly extended and make it possible to perform flexible ureteroscopy in patients while receiving antithrombotic therapy. So, to summarize, of course, we know there are some various guidelines and recommendations from several organizations, but unfortunately there is no clear consensus until now. Clinicians, however, are encouraged to critically endorse them to develop patient-specific evidence-based management plans tailored to meet the patient's needs. There is a need for high-quality prospective multi-centered studies, need for multidisciplinary approach tailored to the patient's risk of thromboembolic event versus the risk of bleeding. There is a need for collaborative effort from urologists and colleagues from other specialties to yield high-quality evidence and work towards a consensus for perioperative management of antithrombotic treatment. And for sure, endourology is the solution for these challenging cases. These great advancements that we have seen in endourological armamentarium, together with increasing surgical experience, make it possible to safely treat complicated patients' cases. These patients should be appropriately, however, counseled and informed about the treatment options and risks in order to guide treatment decision-making and informed consent. To determine the risk for individual patients, future research in this area should consider risk stratification for type of anticoagulation or antiplatelet therapy, doses, and indication for therapy. Thank you very much.